So thank you very much for the invitation to speak with all of you this evening. It's an honor to speak to this society. Some of your past members are well known to me from my work, whether Herman Blumgart, Walsh McDermott, Alvin Feinstein, or Victor McCusick. I'll point out two of them who come up in my history I'll be sharing tonight, and many others I know of because of their standing here in the Boston medical community. Now, I'll be talking about a problem that you're all very familiar with, the problem of coronary artery disease, but I hope to tell parts of the story that you might not have come across before to demonstrate what history can teach about the ethics of innovation in medicine, something that's at the core of so much of our work. Now, heart disease, of course, has been the leading cause of death in this country now for over a century. And cardiologists and cardiac surgeons have long been interested in treatments of coronary disease. They have worked hard and imaginatively across the 20th century to develop treatments. And if you talk to people now, they will often truncate this history and say that cardiac surgeons first really achieved success in the 1960s with the advent of coronary artery bypass grafting. And then this precedent set the stage for cardiologists a decade later to develop coronary angioplasty. And by the 1990s, these two procedures dominated the medical landscape. When I started working on this history around in the 1990s, I was told by one of the trustees at Mass General Hospital that three procedures, coronary angioplasty, coronary angiography, and coronary artery bypass grafting, produced fully 1/3 of the revenue of Massachusetts General Hospital. I suspect it's not quite so high now, but it's still a major source of operations for any academic medical center. But throughout the history of these procedures, there has been fierce debate about their effectiveness, complete with accusations of overuse and then furious debates about that. I'd be happy to give that talk. I'm afraid it might cause some people here indigestion, especially if there were any interventional cardiologists here. So I'll pass on that for now and focus on a different story about this history. And the question I'm interested in is, where is the line between experiment and innovation in surgery in particular, but in medicine more broadly? The basic dilemma that all doctors face, and would-be medical innovators, not just doctors, but as long as patients seek relief for their symptoms, which they always will, and as long as surgeons and other physicians think that a better treatment might exist, and they always do think that there are better treatments around the corner, then those clinicians will always be at a risk of crossing a line between clinical care and experiment. And so I'll describe several cases from the history of surgical treatments for coronary disease in which surgeons took extraordinary risks with the lives of their patients, and in which they were startlingly willing to believe that their interventions worked, even some very odd interventions, as I'll demonstrate. And we have every reason to believe that surgeons, and I think all clinicians, face similar risks of exaggerated therapeutic enthusiasm in their work today. So many histories of coronary vascularization will trace the story back to Alexis Carrel, who was a French surgeon, but who did most of his work in the United States. And he was responsible for pioneering many of the key techniques of vascular surgery that are still in use today, including coronary artery bypass grafting. However, he first attempted the procedure on a dog, trying to perform the procedure on a beating heart, and for a variety of reasons, he could not succeed with this procedure. Now, his work was widely celebrated. Even after his attempt with bypass surgery failed, he was still able to present at the New York Academy of Medicine and be covered in the New York Times in the medical record. And he won the Nobel Prize in 1912 for his contributions to vascular surgery. But his technique of coronary artery bypass grafting attracted very little interest at the time and was not really attempted again until the 1940s. Now, in the absence of having this direct approach to treating coronary disease, the surgeons who did attempt to treat coronary artery disease took very different approaches. One approach attempted to relieve angina pectoris by disrupting the nerves that go to the heart. Charles Mayo, one of the founders of the Mayo Clinic, went first. A patient who was a major in the Army during World War I had to give up his military career because of intractable angina. In 1913, Mayo described how he removed both sympathetic nerves, that is the middle and superior on both sides, and wholly relieved his pain. Now, despite the seemingly promising start, sympathectomy followed a complex course. One problem at the time was that surgeons really did not understand the structure or the function of the autonomic nervous system. There was no consensus about whether stimulation of the sympathetic nervous system would lead to dilation or constriction of the coronary arteries. Others were worried that the procedure had no impact on blood flow and that all it was doing was blocking pain. And it wasn't clear that you actually wanted to block pain transmission from the heart because people would then not realize that they had triggered an angina episode. And so people were afraid that by blocking this pain signal, you were preventing them from receiving a valuable warning. A very prominent British cardiologist, James Mackenzie, furiously condemned the procedure in 1924. As he said, when the surgeon is profoundly ignorant of the morbid condition for which he operates and of the functions of the structures which he mutilates, it is impossible to conceive anything more detrimental to progress. Surgeons were not deterred, and they continued to work very hard to develop sympathectomy, with a lot of the innovations taking place here in Boston, both at the Peter Brigham Hospital and at MGH. The surgeons had two goals. They hoped that some patients might actually benefit from the procedure, and they also hoped that as they did these operations, they would generate new knowledge about the structure and function of the sympathetic nervous system. Elliot Cutler, who's a very famous chair of surgery at the Brigham, wrote in 1927, even if these procedures fail ultimately to prove of practical value in clinical medicine, the stimulation towards the study of cardiac pain and the innervation of the heart will have been great value to the profession. So even if our patients don't benefit, at least we will have produced valuable knowledge along the way. And so this was a case of well-intentioned surgery performed without understanding the underlying physiology. And in this setting, every operation literally was an experiment. The surgeons did not understand what they were doing, but they were willing to try. It's not at all clear to me what the patients understood of this dynamic. Did they realize that they were engaged in this kind of experimental work? Now, meanwhile, the second approach that was developed, again, largely pioneered here in Boston at the Brigham and the Beth Israel Hospital, was thyroidectomy. And so physicians had long recognized a link between heart disease and thyroid disease. Patients who became hyperthyroid often would report angina. And so in 1925, Henry Christian, who was physician-in-chief at the Peter Brigham Hospital and a member of this club, wondered whether removing the thyroid gland might help his cardiac patients. As he explained, a lowered metabolic activity from thyroid deficiency may be a conservative process, a form of cardiac rest that is advantageous to the heart. And so he and a group of Boston surgeons began to remove initially just parts of the thyroid gland, but eventually the entire thyroid gland from their patients in hopes that this would prevent or relieve angina. Elliot Cutler was very taken with this idea. He thought it was even the idea that you could remove a normal thyroid gland in hope of modifying heart disease really captivated his imagination. He described this as the surgery of the future. You would alter one part of the body to have an effect on a different part of the body. Now, surgeons knew that this was a dangerous gambit. The question was whether the benefits, reduced angina, were better than the side effects, which was complete myxedema. Now, surgeons would pay attention to the kind of side effects their patients were reporting, but they were often quite dismissive. So many of their patients, for instance, reported neurological complications or cognitive dulling after having the thyroid glands removed, and Cutler dismissed this altogether. He said, although most of them believe they are slowed down mentally, we have difficulty in attributing this possible change to the imposed myxedema, but see in it rather the normal slowing down with age. To determine which of his patients might have thyroid responsive heart disease, Cutler's team at the Brigham developed an adrenaline challenge test, as you see in this case in 1933. They would inject adrenaline to the patient and see if the heart responded to this challenge. And if you can make out the clinical notes on the side, 10 minutes after injection, this patient developed a full-blown myocardial infarction. This was interpreted as a positive test. The patient had thyroid responsive heart disease and was referred for thyroidectomy. And again, this demonstrates the kinds of risks that surgeons, again, well-respected surgeons, and he wasn't some crank, he was chair of surgery at one of the most famous surgical programs in the country. There were, of course, skeptics, famous skeptics, including Michael DeBakey, who wrote in 1937 that the surgery was pointless because the patients required so much thyroxine after surgery in order to treat the myxedema that the surgery had produced that they then developed recurrent angina pectoris, and you were just right back where you had started. Now, other surgeons developed other techniques for bringing blood to the heart. Claude Beck, again, a man with an impeccable surgical pedigree, He had trained at Hopkins, Yale, and Harvard with Halsted, Cushing, and Cutler, developed a whole series of operations. This is just one of them, the Beck 1 operation. He would abrade the epicardium, suture a tissue graft from some other bodily tissue onto the heart, and then put a partial ligature around the coronary sinus to make it harder for blood to leave the coronary circulation. And he hoped that this procedure would redistribute blood throughout the heart, and by slowing venous outflow, it would give the heart more time to extract oxygen from the blood. Another surgeon, Arthur Weinberg, who became chair of surgery at McGill, developed a whole series of procedures in which he would encase the heart either in sponge or omentum, transplanted from the abdomen. And he had various theories for why this would help, theories that went back to this notion of the healing powers of primordial tissue. In another procedure, he would take the internal mammary artery and implant that directly into the myocardium itself. So he'd put a bleeding vessel into the wall of the left ventricle, and he believed that the porous sinusoids in the myocardium would pick up this blood that was now gushing into the heart through the internal mammary artery, and this would again relieve coronary artery disease. And then the last one I'll mention was a technique that was actually developed in India, but then briefly taken up in the United States, an attempt to replicate the anatomy of the heart of reptiles. Reptiles do not have coronary arteries. Their myocardium is perfused by channels that come in from the ventricular chamber. And so what he did is he took a needle and poked lots of holes into the inner surface of the myocardium to see if this would work. Generated a lot of enthusiasm at the time. Oh, and sorry, one last one, endarterectomy. Endarterectomy, a wholly plausible procedure, had been developed for use in many arteries throughout the body. In the 1950s, Charles Bailey at Penn and William Longmire at UCLA tried to adapt the endarterectomy for coronary artery disease. As Longmire wrote in the New England Journal, it seemed to us the most effective means of increasing myocardial blood flow would be to remove the obstructing atheromatous plugs from the coronary arteries themselves. It made good sense, but if you attempt an endarterectomy on very small arteries, you often get into trouble. The Longmire's team in Los Angeles had a 40% operative mortality rate in their initial series. They worked really hard and got operative mortality down to 23%, and then they declared the procedure ready for prime time. Cleveland surgeon Donald Effler, who becomes one of the most famous of the cardiac surgeons of the time, praised their tenacity. And I can never tell whether this was slightly tongue-in-cheek, but he said, this is heart-rending work. And the fact that they have had the courage to continue, even with a rather forbidding initial mortality, is much to their credit. Now, as I said, these were not crank surgeons. These were many of the leading figures in the field at the time, pursuing a series of procedures, many of which we would consider reckless and dangerous, but they were quite thoughtful about the outcomes that they would measure. And if you look at their reports, they were measuring all sorts of things. Did the patient survive the operation? Did the surgery improve some physiological measure of heart function? Did it relieve symptoms? Did it improve their functional capacity? Did it improve their prospects for long-term survival? So they subjected a lot of their patients to pretty close study. And it's really astonishing the kinds of things that they reported. They had excellent outcomes, which are completely puzzling to any reader today. For instance, Cutler noted that many of his sympathectomy patients substantially reduced their daily use of nitroglycerin. And this was an easily quantifiable question. How many tablets were they using a day? Dramatic reductions. He said one of his patients felt so well after surgery that he was able to take up smoking again. Surgeons were especially careful in studying the thyroid patients. Herman Bloomgart, a member of this club, and the staff at Beth Israel Hospital looked very closely at the outcomes achieved by surgeons. They measured electrocardiograms, blood flow velocity, exercise tolerance tests, skin temperature, venous pressure, work capacity, many things to see what this procedure was doing. A lot of this work was done in the 1930s at a time of great unemployment. The ability to restore a patient to the ability to work was a major outcome for them. And they reported that many of these thyroidectomy patients indeed could go back to work at a time when this was really important for the local and national economy. And Bloomgart's team at the Beth Israel also recruited the social workers. MGH was the first hospital in the country to have a hospital-based social work program. Beth Israel followed quickly. And they would send the social workers into the patient's homes and community to see the ways in which the operation had had an impact. And they found that many of the patients reported that their life was more meaningful. They had become less of a burden on their families. They had fewer hospitalizations, and they were more economically productive. This is from a thyroidectomy. And some of them, and this is from the work of Claude Beck, took videos to give you a sense. So here's one of his patients. This was filmed around 1960. I hope the audio works. This is a woman who had already suffered 2 heart attacks, and her father and daughter had both died of heart attacks.
Age 51 years. I have pain in the chest and I am short of breath. The electrocardiogram is negative. Exertion brings on pain. I have a heavy, choking sensation. The drugs, including Demerol, give me some relief. I am limited to only light housework.
So he plans his procedure, the Beck 1, and this is what this procedure looked like.
The entire surface of the heart is gently abraded. The coronary sinus is narrowed, but not shut off. Asbestos powder is sprinkled over the entire surface of the heart. 2/10 gram of asbestos powder is used. It is a mild inflammatory agent and produces collaterals.
Obviously, the cultural meanings of asbestos have changed enormously since 1960. And so that was done, and here she is afterward.
My operation was done 1 year ago. I have had an excellent result. I have no anginal pain and take no medication whatsoever. I do all my own housework, and I have not seen my doctor professionally since the operation. He and my friends are amazed at the results. My blood pressure used to be 90 to 100. Now it runs from 130 to 140. I do everything I want to do. I go out. I have people come to my house. I like to attend social functions, and I like to dance. I actually have a new life.
So a lot of symptoms, but also a very concrete physiological measure, improved systolic blood pressure. And if you don't, you can take her husband's word for it as well.
Since the operation, my wife is a new woman. I can scarcely believe that the result of the operation could be so good. Before the operation, she was incapacitated. She could scarcely do any of her housework. The gloom of weakness, pain, and suffering was always present in our home. Now a new life has been restored to her, as well as to me and my family. She enjoys social events. She likes to dance, and she likes to wear pretty clothes again. She lives a normal life.
Now, obviously, you could talk for hours about these videos, which reveal as much about 1960s home life as they do about cardiac surgery. But again, a series of very specific efficacy claims. And this is one of my favorite ones. This is from the correspondence between Donald Effler at Cleveland and Arthur Weinberg in Montreal. And the basic story here is that one of Weinberg's patients, who he had performed a sponge procedure, so he had wrapped a sponge around the heart, did so well after surgery that he was able to return to his usual activity, which meant that he died in a fight after spending a night with a woman he had picked up on the street. As Weinberg wrote, the patient had improved sufficiently after the operation to return to work and do those things that led to his death. Effler responds, perhaps if you emphasize the effect of your operation on the libido, it might provoke some more enthusiasm from our medical colleagues. As I said, these outcomes are a complete mystery to me. The procedures, at least as we understand them, should not have helped much. The thought of powdering asbestos all over the heart makes everyone cringe. Now, they relieved angina, but this is easy to dismiss. Almost anything that surgeons have ever done to patients have relieved angina. They improved a whole series of different kinds of physiological measures, and that's much harder to dismiss. Were surgeons fudging the results? And some people will notice that in the video, you can see that their eyes are tracking a script. And so the question is, who wrote the script that they were reading? But it's hard to imagine that these people, again, these were the luminaries of American surgery, were actively fudging all of their results. Were they cherry picking which results to report? That's certainly possible. Some people say, well, was this just a placebo effect? And I don't know, if you believe that placebos, inert pills, can have active physiological effects, it's easy to believe that these much more invasive procedures might have tapped some much more profound psychophysiological effects, but I'm not really sure how to explain what you see. And so this question of how can these procedures be understood is puzzling. Surgeons clearly had unwarranted optimism in what their interventions could achieve. We can see their desire to have positive outcomes in the patient's post-op experiences. They were likely willing to downplay any adverse effects and sweep those under the carpet. And I think all of these desires are very much in play in medicine today. Now, a new technique, but really this was the old technique that had been developed decades earlier, coronary artery bypass grafting, is gradually revived over the 1960s. There were many early attempts in the 1960s, including by some very prominent people, David Sabiston at Duke, Michael DeBakey in Houston. They either didn't recognize the value of the procedure or were unable to convince their colleagues. And the key innovation, which was persuading colleagues to take this seriously, came with the work of René Favaloro at the Cleveland Clinic. He performed his first CABG procedure in 1967, published it in 1968. Very quickly, Cleveland Clinic was doing 1,000 a year, and within a decade, the country was doing 100,000 a year. Now, most of the historical writing about the emergence of coronary artery bypass grafting has focused on who deserves credit for this, but that ignores a whole series of much more interesting questions. One is the nature of the innovation. Favaloro didn't really come up with this idea. He had learned about it from the vascular surgeons at the Cleveland Clinic who are using saphenous vein interposition grafts to treat renal artery stenosis. And he said, if they can do that on the renal artery, I can surely do that on the coronary artery. He then completely skipped surgical research or animal research. He saw the vascular surgeons perform this on the kidney, and he went directly to human trials. That was probably essential to his success because for a variety of reasons, this is a very hard procedure to do on dogs who do not have atherosclerosis. So by skipping animal research, which had bogged down DeBakey's group, and going straight to human research, he was successful, but it was also incredibly reckless. Now, he had an interesting risk management strategy. He did the procedure for the first time on a woman who had right coronary artery disease, and he guessed that if he totally destroyed her right coronary artery, she would still survive. And so that would be okay. And that may have been a correct assessment. And the other thing that's interesting about all this, as had happened with sympathectomy, he really did not understand the underlying pathophysiology. There were major debates at this time about whether coronary artery disease is mostly a focal or diffuse process. In the early 1960s, when the Cleveland Clinic was trying a variety of different procedures, most of their writing described coronary disease as a diffuse process. Effler, writing in 1963, said that he didn't think endarterectomy was going to work very well, saying, the overwhelming majority of patients studied with selective coronary arteriography demonstrate a diffuse pattern of coronary atherosclerosis. It is unlikely that the direct surgical approach will offer relief when multiple obstructions have occurred. It was only after Favaloro develops and successfully demonstrates coronary artery bypass grafting does Cleveland Clinic change how it's interpreting angiograms, and they start to report it as a focal disease that can be treated well with this procedure. And then again, as happened before, they were quite willing to downplay any kind of side effects. For instance, any cardiac surgeon in the 1960s had prior experience with heart-lung machines for doing valve repairs. They knew that a very high percentage of these patients who had open heart surgery had severe neurological complications. The first generation heart-lung machines were not nearly as safe as the ones that are in use today. And that even though they knew the risk of neurological complications, for the first decade, there were no studies of the neurological complications of coronary artery bypass grafting. And there was also an interesting way in which surgeons' own historical knowledge had left them skeptical. So Charles Bailey, who had been one of the pioneers of endarterectomy, was very critical of the Cleveland Clinic team. As he wrote in 1970, 3 years ago, he, Donald Effler, was describing the operations they were then doing as the next best thing to sexual intercourse. Today, he'll tell you it wasn't so good, and then he was praising coronary artery disease. The question really is, what will we think of these saphenous vein bypass procedures in 3 years? Well, by 1973, saphenous vein bypass procedures had totally transformed cardiac surgery. So one question comes up, why were these things so successful? Why did they catch on? Part of the appeal was that they relieved angina, but surgeons knew that, again, anything they did could relieve angina. Some of the appeal was the aesthetics of surgery. Coronary artery bypass grafting was much easier to do than many of the procedures they had been attempting in the 1960s. And then some of it was the visual evidence that was provided by arteriography. As Effler wrote, arteriographic proof that the pathological ligature has been removed effectively and myocardial perfusion has been restored is prima facie evidence that the needs of that individual have been met. And because of this confidence in the physiological logic of the procedure, many surgeons refused to participate in randomized clinical trials. And that became a huge debate in the 1970s. Be happy to take questions about that, but that'd be a different story to tell. Now, in this case, they were right. Coronary artery bypass grafting is a really good procedure, especially compared to what had come before. But the way that they got to this procedure, again, demonstrates the dangerous dynamics that are often at the heart of surgical innovation. Now, surgeons might say that this history and its lessons are relics of an older era. People will argue that surgical science is far more advanced now than in the past, and that the ecology of cardiac care is radically different. In the early 20th century, there was no accepted standard of care, and anyone who had any idea, no matter how strange it seemed, could take a crack at making a breakthrough. But now there is a dense network of treatments for coronary disease, behavioral, pharmacological, interventional. The barrier for entry for a new innovation is much, much higher. And in theory, this should protect patients from unwarranted experimentation and prevent surgeons from repeating the mistakes of the past. But let me show quickly that's not quite so clear. So one of the old techniques that had been tried and abandoned was myocardial acupuncture. Well, that technique was actually revived in the 1990s using lasers, not needles, to make the holes into the inner surface of the myocardium. The new technique, I'm sure lasers were cool, but it didn't solve the basic logic, is that there's no way to get blood to flow into a contracting left ventricular wall. There was no physiological rationale for why this would work. But for about 15 years, there were a whole series of enthusiastic trials that were published. It was really pioneered in the US down in Houston. The New England Journal of Medicine published the results of 2 favorable trials of transmyocardial laser revascularization in 1999, and accompanied it with a hugely skeptical editorial that said there is no way this could work. Yes, they have shown results that it does seem to work. This must be a placebo effect, or these must be biased researchers. And I would love to have been a fly on the wall when the journal agreed to publish these trials and then publish this editorial. But unfortunately, the journal shreds its archive. So there's no record of this. Similarly, that part of Beck's old procedure, coronary sinus occlusion, was revived in 2004, not doing it surgically, but doing it through a catheter-based technique. People did a sham-controlled randomized clinical trial, published in New England Journal of Medicine in 2015, with positive results, just like Beck had gotten. And as the authors admitted, there was still no good rationale for the procedure. By disrupting outflow from the coronary veins, that is going to make it harder for coronary blood to flow into the coronary arteries. So they said this makes no sense. We had very positive results. They didn't understand what was happening. And so I suspect anyone who's here could also tell your own stories about treatments that have existed, that still exist, about which people are skeptical. And the history helps us understand why some of these treatments persist. Doctors continue to be motivated by their desire to help patients, which is obviously exactly what doctors should be doing. The treatments now are much better than they were in the first half of the 20th century, but they're still imperfect. There's always a desire to produce better treatments for our patients. And surgeons are often willing to put their faith optimistically in various physiological theories for how a procedure might work. There's a lot of pressure to produce favorable results, and there are a lot of pressures to downplay adverse effects. As long as these conditions exist, physicians will remain at risk of crossing the line between clinical care and therapeutic experiment. For people who want to know more, I've published a fair amount, although the material in this talk is part of a book that is still in process. It will get finished someday, but I'm happy to take questions about any of this. Thank you.